The last 40 years have been fantastic. It's the time I've spent in healthcare. And we've seen the second revolution in healthcare. And if you look at the first PowerPoint we've sent you, you can see on the right hand side the fantastic achievements of the second healthcare revolution. The left hand side shows the first healthcare revolution. But we're now in the third healthcare revolution, driven not by science, but by citizens, knowledge and information technology. You see, it's been amazing what has been achieved, but if you look at the second PowerPoint, you'll see that every society on earth, every society, tax-based, insurance-based, public-private, faces the same 5 problems in healthcare. Failure to prevent the preventable, inequity, harm, waste of resources, and unwanted variation in almost everything you want to look at. And for the next 40 years, increasing need, due principally to population ageing, will have to be met without increasing resources. And it'll have to be met with a lot less carbon. Now, there's a number of changes need to take place. Everything, it's a new paradigm. One that focuses on value as opposed to quality. One that focuses on systems as opposed to institutions. And here are the sort of questions in the third PowerPoint that I ask you to see if you can answer in the Northeast. Don't worry if you can't, because I don't know any part of the country, or indeed any country in the world, where these questions can be answered. Is epilepsy care in Northumberland better than epilepsy care in Durham? How many asthma services are there in the Northeast? Who's responsible for people with bipolar disorder in Middlesbrough? Systems. Population-based, accountable, integrated systems. But what do I mean by a system? Well, here's the jargon, the new language. And actually, if I were with you, I would be saying, I'm going to ban for this meeting the use of the words primary and secondary, acute, community, and outpatient. These are 19th or 18th century words. Here's the language of the 21st century. System, network, pathway. System, network, pathway. A system is a set of activities with a common set of objectives and an annual report. A network is a set of organisations that delivers the system, and the pathway is the route most patients follow through the system. System, network, pathway. And you can see more about these definitions if you look at our website, www.bbhc.co.uk. Here's another way to think about systems, this picture in the next PowerPoint. And this is more 21st century language. Objectives, criteria, standards. Objectives, criteria, standards. And I've just put in one objective here, an objective for an asthma system to diagnose asthma quickly and accurately. I often ask people to design objectives, and if you look at the next list of objectives, I've divided the objectives into 2 sets. The top 5 are usually what clinicians come up with. And they are sort of clinical objectives writ large, to diagnose accurately, to treat safely. These are all good objectives. But if you look at the bottom 5, these are what are usually overlooked. But as we move into a world of limited resources, where clinicians are responsible for the stewardship of resources, then we have to have objectives like to make the best use of resources or to mitigate inequity. So these are the objectives of the system. For each objective, there has to be one or more process or outcome criteria and standards. Objectives, criteria, standards. If you look at the next PowerPoint, you see the hierarchy in the network. In the 20th century, it was a hierarchical system. Professor, consultant, GP. In the 21st century network, it is professor, consultant, GP, pharmacist, specialist nurse, patient in the middle. And you see all the circles are of the same size. The patient is as important as the professor. If the patient doesn't take the medicine recommended by the professor, who's more important in the value chain? Networks. So we move from hierarchies to networks, from institutions to systems, from hierarchies to networks. What are the implications of this for specialist practice? Well, the the PowerPoint with the single big blob in the middle depicts the work of a certain wonderful Dr. Jones. She's a respiratory physician in Derby, and she's terrific. She does evidence-based healthcare, patient-centred care. She does high quality care, and every year she tries to do better and better against explicit standards. But Dr. Jones, how many people are there in South Derbyshire with chronic obstructive pulmonary disease? Well, we do a little survey and we find 1,000, as shown in the next PowerPoint. And as you can see here, the small circle is there's 100 patients who would really benefit from our specialist service, from referral to outpatients. But remember, we've done away with outpatients. She needs to think in population terms. She needs to think about patients she doesn't see and never will see. So Dr. Jones, we'd like you 1 day a week to think about the population of people with COPD and not just the people referred. So if you look at the list of tasks in the next PowerPoint, you can see a range of things that she does. She's responsible for identifying all the GPs, the generalists, and the new generalists, greeting them when they come to the county. She's responsible for finding the pharmacists, because they're very important in respiratory disease, for building the network, for bringing people together, for localising the map of medicine, and she's responsible for the annual report, because she's competitive. She wants to do better. She wants to do better than people in South Nottinghamshire. Population medicine. That's the pattern. Not for everyone. I'd like every clinician to think about the population, but within a team of 4 or 5, one should have explicit responsibility for working with general practitioners and patients and building a network to deliver the population-based and population-accountable integrated system of care. Now this requires new concepts. And the next PowerPoint shows a picture of Avedis Donabedian and the podcasts that we run from Better Value Healthcare. And there are a number of great books. For example, this is General System Theory by a man called Ludwig von Bertalanffy, who really invented the concept, a biologist in the 1930s. But I think what's influencing me most, if you look at the last PowerPoint, is the world of the ants. And studies of ants are epitomise what I call complex adaptive systems. And this is a book called Emergence, and it's based on studies of this ants. This is the big bumper book of ants by Wilson and Hall Dobler. And the interesting thing about ants is they're altruistic, they're adaptable, they help one another, they work at the level of the colony, not the individual. And the concept of emergence is that in complex adaptive systems, for example, let's imagine you wanted to improve epilepsy in the northeast. How would you do it? Bureaucracy, chief exec writes to so-and-so, writes to so-and-so. Doesn't work. The market, I don't know how you run a market, but it's not very good evidence to support it. So what you would do, you'd bring all the people with epilepsy and their parents, teachers of learning disability, because lots of children with learning disability have epilepsy, and neurologists and neurosurgeons and electrophysiologists. I'd bring them to somewhere like St James's Park. I still call it St James's Park. Or a hotel or somewhere. And you say, ladies and gentlemen, there is no more money, but I'm sure you can think of ways in which the service can be better. And emergence, ideas emerge. So, the 20th century was the century of the hospital. The 21st century is the century of the system. I'm sorry I can't be with you. I hope I will meet you all in the near future.